Hello, today we'll deal with antipsychotics that we give to schizophrenic patients, and we are giving it intramuscularly or subcutaneously. That is risperidone. Risperidone is very interesting because we can give it subcutaneously, meaning under the skin. Sub is under, cutaneous is skin, under the skin. And also we can give it intramuscularly, so meaning in the muscle. Okay, and now we have 4 doses of intramuscular. We have Risperidone Consta, that is the name of the intramuscular type, 12.5, 25, 37.5, and 50. 4 types of doses. The difference between these doses are 12.5. That means that we titrate up until we reach a good target dose where we have low symptoms and very few side effects. And these 2 important questions are for every medication in the field, because we need low symptoms and we need low side effects. And therefore we titrate it up. We go step by step. We start with 12.5, then in 4 weeks, after 4 weeks we give 25, then after 4 weeks we give 37.5, and then we give 50. If the patient starts to have very much of side effects, or the symptoms already disappear at, let's say, 25 milligram, then stop there. Stop with 25 milligram and keep that level as a maintenance dose. You don't need to go up to 50. That is our maximum dose. Keep it low. If it's possible, then keep it low. Good. Then we have Risperidone Perseris. That is our subcutaneous injection. And here we give it every 4 weeks. And we have 2 different doses, 90 and 120. So 90 and 120 for subcutaneous risperidone, and the name is Risperidone Perseris. The name of the intramuscular one is Risperidone Consta, and that is having 12.5, 25, 37.5, and 50. So we have 4 doses of intramuscular one, we have 2 doses of subcutaneous one. The difference being the subcutaneous can be given every 4 weeks, intramuscular can be given every 2 weeks. So the subcutaneous is better in this regard because we don't need to give it so frequently, only 12 times a year, which means better than giving 365 tablets a year. Okay, and that's the benefit of giving subcutaneous. And we give subcutaneous, for example, in the abdomen region. So under the skin, you will take the skin, you will move it like this, so squeeze it like this, and then go inside in the skin. It doesn't hurt. The needle is so thin that you will not feel it. Almost, it's like a small, very small diameter of this needle. Under the skin, every 4 weeks. You can manage it. It's not a huge problem. Okay, and we have now 2 types. The oral overlap, what we call oral overlap, is when we deal with the oral medication continuously or stopping them. So that's the question. Should we continue them or should we stop them? It differs here, because in the intramuscular one, we need to continue 3 weeks. In the subcutaneous one, we need to stop it. There's no need to have an oral overlap. Oral overlap means that you continue the oral tablets and you get the injection and you continue it for 3 more weeks. You take the tablets, so now you have actually the tablets and you got the intramuscular injection. And you continue it 3 weeks. For subcutaneous, you don't need to continue it. You stop the oral medications and you switch to subcutaneously directly. So the stepwise fashion, as we said, that was for intramuscular injection. For subcutaneous one, there's actually only 2 doses. We have 90 and 120. You begin with 90, and if it does not work, then you continue with 120. And a very important point here is that if the patient was taking oral tablets, let's say 3 or 2 or 4 milligrams, or 2 to 4 milligram oral tablets of risperidone, then we can give subcutaneously. It's no problem. But if the dose of the oral tablets was more than 4, so 4, 5, 6 and above, until 8 we call it. 8 is the, I would say, the maximum doses of risperidone orally. Above 8, it does not really help you any much. So it will only give you a lot of side effects. And if you have a span of 4 to 8 now of oral tablets, then please don't give subcutaneously. Give instead the intramuscular then, okay? So instead give, for example, 50 or 37.5 or 50 milligram, because the dose of the intramuscular is a little bit higher. I know it sounds strange now because I say that in subcutaneous we have 90 and 120 milligram. You would think that, yeah, but there's more milligram here. Yes, it's true, but it's other composition. So in the intramuscular one, you have a 37.5 or a 50 milligram being even stronger, one can say, than the subcutaneous one of 90 or 120. So please, subcutaneously, if it's less than 4 milligram oral tablets, then you give subcutaneously. If not, then please give the intramuscular one if it's higher. And then we can start with, let's say, instead of starting with 12.5, we can start with 25. But I would say I would rather start always with the lowest dose. And why? Because we have this oral overlap. That means that the patient was taking the oral tablet every day for 3 more weeks, and he got the intramuscular injection. So I would start with 12.5, and then when I would give the 12.5, and then we give it every 2 weeks. Every 2 weeks, 12.5, 12.5, and we titrate, meaning we increase the dose with 12.5 again after 4 weeks. So that means the patient was coming to me. He was taking oral tablets. I say to him, please continue to take the oral tablets. I will give you a shot now of 12.5. In 2 weeks, you come back, I give you another shot of 12.5. In 2 weeks then later, that meaning 4 weeks have elapsed, I give you now a 25 milligram. Okay, so you see, I gave one shot, 12.5, then in 2 weeks time I gave 12.5 again, and then in 2 weeks time, meaning after 4 weeks, I gave 25. Then we go on and we give 25 2 weeks later, and then 2 weeks later we will give 37.5. You get the point. The point is every 4 weeks you increase the dose with 12.5. And intramuscular injections are given every 2 weeks, so not every 4 weeks. You give the intramuscular injection every 2 weeks, but you increase the dose every 4 weeks. In subcutaneous, it's more simple. We was having a lower level than 4. We gave 90 milligram, and we saw that we can give this 90 milligram every 4 weeks. The patient was stabilized. The patient had no more symptoms. Then we stay with 90 milligram. If the patient was having a lot of side effects, then we consider going back to the oral tablets, removing this. So what I'm meaning, and in the other cases, when the patient is having more symptoms, so the symptoms are there, then we need to step up to 120 milligram. Every 4 weeks we give this subcutaneous. So that's it. I thank you very much for listening, and have a nice day. Bye bye.